You should straight away put ICD or CRT, or you should wait. So in the Egyptian Heart Journal, there was a wonderful study by Navjot Kaur, whether introduction of ARNI will reduce the need of device therapy like CRT or ICD in patient with reduced ejection fraction. Let's see. So what are the recommendations for ICD in a patient with heart failure? An ICD is recommended to reduce the risk of sudden cardiac death and all-cause mortality in patients who have recovered from a ventricular arrhythmia and have a survival of at least 1 year ahead. Then yes, you can put an ICD in such patients. An ICD is recommended to reduce the risk of sudden death and all-cause mortality in patients with symptomatic heart failure with ejection fraction less than 35%, more than 3 months of optimal medical therapy, provided they are expected to survive more than 1 year. So generally in MI patients, if patient has MI, you have to wait at least 40 days and then only look at the ejection fraction and then put an ICD. Or if the patient has a cardiomyopathy, dilated cardiomyopathy, then also if the ejection fraction is less than 30-35%, you can put an ICD to prevent sudden cardiac death in such patients. So if patient with having symptoms because of HFrEF, treat all the reversible causes like maybe beriberi or any selenium deficiency or thyroid or so many other reasons which are there. But if the patient is still symptomatic and has NYHA class 2 symptoms, LVBB is there, and if especially it is more broad QRS like 150 milliseconds or more, you can put a CRT to improve the ejection fraction of the patient. But if the patient is symptomatic and the QRS is narrow and ejection fraction is still less, 30-35%, you can add an ICD to such patients. But there is a lot of gap in the evidence, like there are non-responders to the treatment. Because of the frequent VPCs or progressive heart failure, there can be no response to treatment many a times. So what you can do is replace the ACE inhibitor with an ARNI in such patients because it improves the ejection fraction, reverses the adverse cardiac remodeling, decreases the VPC and sudden cardiac deaths also of such patients. And there is a chance that such patients, once the ejection fraction improves, he might not require a CRT and ICD.